Yeah, I'll let them in now.
Hello, welcome everybody to C3's international seminar. We're just on 1 o'clock, so we'll wait a few minutes as people are joining, but you're all very welcome. So good morning, good afternoon, good evening, depending on where you are. My name is Christine Hancock from C3 Collaborating for Health, and really delighted to welcome you all here today to the latest of our international seminars. And I'm particularly pleased to be able to introduce Professor Jo Ivey Boufford. Jo and I first met when she ran an organisation called the King's Fund in London. And so she's lived in this great city, as we often call it, for many years, but some while ago. And she's now calling us from New York. And the issue of cities globally is increasingly becoming such a really big issue, as well, I'm sure Jo will give us more of the details and facts and information. But over half the world's population now lives in a city. C3 Collaborating for Health has a series of international seminars. There used to be breakfast seminars and we had them in person, and then we had to wait until people actually came here. Now we don't get the lovely breakfast that we used to give, and you don't get the opportunity to really chat easily to people, but we are able to reach people from a much wider range, both as speakers and as participants. And at C3, we're about believing in how to make it easier for people to live healthy lives. Today, I'm very proud to see in today's paper that a former close colleague, nurse colleague of mine, now the Bishop of London, is chastising our government for the increase in inequality. Quite unusual for people like a bishop in the church to speak out politically in that way, and really good to see it happen. I'm not going to talk anymore other than to say you're very welcome here. Jo's going to talk for half an hour or so and be very happy to take questions, to facilitate a discussion and see how it goes. So welcome especially Jo for coming here, coming online with us today, and over to you now.
Thanks very much, Christine. And I want to thank you very much for the invitation and for your C3 team for inviting me to come. This topic, the work that you do on chronic disease prevention and promoting health in communities has been a bit disappeared by COVID. I'm afraid we're back on the focus on infectious disease as the global priority, but we all know that the NCD issues were one of the highest risk factors during COVID, and certainly are still the major cause of morbidity and mortality worldwide. So we have been very fortunate to be working. I've been fortunate to know Christine for a long time, but also to be working with her in our New York University Urban Health Lab. We've been developing an urban health program at NYU and have been fortunate enough to have our students working with C3 over the last couple of years. So thank you for that, Christine. We can start, I think, going on for, we're going to be talking about cities as drivers of global health as part of the discussion. And I'm seeing, are you okay with this? I'm seeing this still that we're not in the slideshow mode page. You're on mute.
It's all good. We can see it.
It is shared. Can you all see it? I'll try again.
Okay. I wasn't seeing the one image at a time. There we go. That's great. Thank you.
Brilliant.
Yeah. Perfect. Next, yeah, when we think about cities, and I think many of us live in cities all the time, we don't kind of step back and think about the issues of difference in cities and the health of cities. And it's proven to be a really interesting focus area, really starting maybe about 20 years ago. And people talking about urban health now, it's pretty common, but it has not been for quite a while. And we can talk about that as we go forward. Next slide. When I think about working with public health professionals in the health community, these are what I think are some of the great public health challenges for the 21st century. Urbanization is in red there because we'll talk mostly about that, but certainly epidemiologic shifts from infectious disease to chronic disease is a major challenge for the broader health and public health community. The demographic shifts with people living longer. This is really a public health victory. It's often talked about as a looming catastrophe, but I think we have to take credit for the fact that this is happening worldwide, even though it raises challenges for countries and cities. And finally, climate change, which is a major issue for cities, and I'll touch on a few areas there. But next slide. So why did our cities getting attention? I think, as Christine mentioned in her introduction, over half the world lives there now, and the expectation is about 75% of the global population will be in cities over the next 20 to 25 years. And next slide. So while cities are often the economic engines of their country, sort of generating a lot of because of their being centers of communication and culture and trade, generating the funds that drive countries and urban development and national development. They're also responsible for the majority of greenhouse gases, energy consumption, and global waste. And even though they still occupy, surprisingly, a rather small percentage of global land mass, they have a huge effect on the global health conditions. And I think it was recognized that cities needed attention if we were going to meet global health goals. Next. The other thing about cities is that depending on the country, mayors and local governments have varying levels of independence, and cities are often taking leadership in various areas of healthy development. The C40 group has probably been the most visible, often led by the mayor of Paris initially, and this is a group that's been focusing a lot on air pollution, supported by Bloomberg in the early days, and led really a global reaction for cities, and certainly in the United States, city mayors, when the US failed to sign on to the COP agreements when revised a couple of years ago. Mayors around the United States joined together in a network to express their commitment to seeing that their cities met the goals. There's also age-friendly, other networks like age-friendly cities and others that have developed, and a lot of people really like working with mayors. It's very, you can see things happen. You know whether or not you have elective support, political support, and if you have political support, they can often bring other the areas of government together, and you have the community kind of in your face, as they say, having been in city government. You may think you're doing an initiative, but when you go out to the neighborhood and they've never heard of it, you know, you get a reality check pretty fast at urban level. So it makes it really an interesting place to work. So the first challenge of really thinking about urban health is making sure that people know you're talking about health and not health care. And this is a diagram we've used for a while in our International Society for Urban Health, with the idea that all of these sectors, decisions are being made every day that in effect probably have more impact on conditions in communities that promote human health than the actual health sector, which is seen here in red, which would be the healthcare delivery system, and even the public health infrastructure. So if you think about the transportation infrastructure, whether you are making decisions to promote cars or to promote mass transit, has implications for air quality, for physical activity, for availability of green space, for road traffic accidents. You get the idea of the difference. Built environment, people are really looking seriously, we'll talk a little bit about that later, at the kinds of building materials that help to address climate change, make cities energy efficient. Urban planning, the availability of green space has become a very important factor in both mental and physical health, especially during COVID. And in many instances, urban health professionals are kind of going back to their roots, which were often in England when they were really started to try to create healthy cities, right? Healthy environments in model cities, probably maybe even 100 years ago, could have even have been that long, but certainly 50 to 75 years ago. So many of them talk about how they've moved from health into architecture and engineering, and now they're coming back to some of their original concerns in their design for health. And then two circles to focus on the bottom, governance. This is really about the ability of government to bring together multiple stakeholders to agree on shared goals. And this governance issue, while you need political support, the stakeholders around the table are always different. As I say, governance is always local because the people are different that have to get around the table to make decisions. And then that includes the community and the community cohesion variable, which is showing up a lot now as a really important factor in health and quality of life. It's obviously been seen in COVID, is become a much more important skill set for public health professionals and a consideration for broader public health and political practice. Next slide. Just to kind of elaborate on that a bit, this is a document from an International Association for Public Participation, which sort of maps the spectrum between what you might say are the more traditional ways of involving government, which is having telling people and getting their advice, or having a listening session, all the way over to the right, to really doing capacity building as part of the initiatives that we try to promote. And I think the message here is that we need to get communities involved early to identify the health problems as they see them, and to really be involved in the design, evaluation, and implementation of interventions. And I think the British public health structure has perhaps been more attuned to this over the years than that in many countries, certainly in the United States. But this is a really important factor now in training public health professionals. And then just touching on political leadership in the next slide. This is a diagram of what we call a health in all policies approach. It's not new. The Finns wrote a book about it about 30 years ago, but the message is to sort of put in explicit statements, the fact that these decisions, you've got to coordinate decision-making across sectors to improve health and the conditions for health in communities and cities, that the equity issue comes up front and center because there is not an equal distribution of health status among population groups. And this also conceptualized, kind of shifted us from focusing on healthcare, which was a big cost center, mostly in budgets, rather than seeing it more as an input to international development, not just a drag on the budget. The next slide is from a colleague. Whoops, we skipped one, back one, I think. Yeah, this is from Sotiris Vardalakis, who's a good colleague who's been looking a lot about the impact of the natural environment on cities, the sort of bidirectional impact. And I think it's a nice diagram just to say that his work has really been trying to position cities as good actors in climate change and mitigating climate change through both the built and the natural environment. And a lot of evidence is being developed in this environmental area to add to the evidence base on broader social determinants of health. Next slide. So people that have been working on cities, urban health researchers for some time, going back into our international society began in the year 2002, have really used these sort of four concepts pretty regularly, that the unique characteristics of urban environments, if you compare them to rural environments, are density, the concentration of population, diversity, the diversity of population because of growth of cities and migration, immigration, as well as just population growth. The complexity in cities, which has really called on a look at more of a systems approach to urban health, which has really, I think, been very advantageous. And then finally, the issue of inequities in the urban environment. And unlike many areas of research in public health, where you have to remind folks to say, what about equity, what about diversity? It is really baked into folks who work on urban health, because they're very aware that if you take city level indicators, you erase a lot of the variability from neighborhood to neighborhood and miss the fact that you have significant inequities within cities. Next slide. So looking at density, this is the world's mega cities. You can see the population growth, the proposed population growth in these cities. These are sort of the greater, if you will, New York, Mumbai, Buenos Aires area, and just enormous numbers of people living in very, very compact space. And there was a lot of work over on density during the COVID period. One of my colleagues here at NYU saying that density wasn't exactly the villain of the piece in terms of cities' transmission of COVID, that in fact it had some advantages, and that unpacking the positives and negatives of density is a really important thing to do in this area. Informal settlements are obviously a huge risk factor in these large cities that really have not been able to develop infrastructure or tried to manage urban growth. Next slide shows diversity. This is a borough of New York, the borough of Queens, which was very hard hit by COVID. There are about 138 languages spoken. This list of top 10 may be different than the last time I put this slide together, but it obviously creates the kind of diversity that makes people want to be in cities, but it also creates challenges for public health professionals in terms of how did people from different countries who came into the city see government and government authority? How do messages play in different languages and in different cultures? And it's been a really interesting and I think enlarging challenge for public health professionals to take on this diversity in cities in very effective ways. The next slide shows complexity, which was the third item on our list. This is the organizational chart of New York City. It's pretty standard, interestingly. I've looked at organizational charts for cities in the Middle East or in Africa. They're all pretty vertical, which is really the takeaway message here. So while we're trying to deal with this multi-sectoral engagement, the circles that you saw earlier, most cities' government structures are not set up to deal with that. And then there's a question, I think, especially in the UK with decentralization of public health into local government. What's the connective tissue around these organizations relative to the Greater London area in the public health space? So this is a governance challenge for those of us working in urban health. And then the final slide is the inequity slide. This is something very familiar. Sir Michael Marmot sort of gets credit for this with the London subway station. This is New York. And if you look at the sort of central 77 to 85, those are like 4 subway stops between East Harlem and the Upper East Side, East Harlem being one of the more depressed communities in New York, and the Upper East Side being one of the wealthiest communities. And you can see the sort of significant 8-year difference in life expectancy within a very small geographic area of New York City. This is not atypical of many cities. So these kind of findings and the really strengthening of the evidence base, Sir Michael's Social Commission report for WHO led, in the next slide, you'll see the inclusion of SDG 11 in the SDGs. These were not, there was no explicit attention to cities in the Millennium Development Goals. This was a very political decision because it was a subnational level of concern, and most UN activity is at the national level. And it was also separated from 3, which is the health goal, which belongs to WHO. 11 belongs to UN Habitat. The UN agencies are not anymore clear of verticality or difficulties in making connections. But the other one to raise here that's been really important in the SDGs is Goal 17, which really explicitly for the first time invites the private sector into achieving the global health goals, investments, not only in funding, but in know-how to achieve global health goals. And the private sector is very important in cities and often easier to mobilize in cities because of their presence there. Next slide. this is the detail of goal 11. And I think just to remember back to the bubble diagram, you don't see the word health anywhere here, but the elements of making cities and human settlements, which really refers to informal settlements, inclusive, safe, resilient, and sustainable, are things like housing, transportation, disaster preparedness, air quality, green space. You get the idea. So all of these factors we would now, I think, as health professionals think of as determinants of health, but because UN Habitat and the generators of this document were very much planners and housing people, you don't see the word health really explicitly in this, nor do you see attention to cities explicit in goal 3. There is a separate and parallel document, next slide, which is the New Urban Agenda, which was issued in Ecuador about the same year as the year after the SDGs were issued. And this is an effort to really look at the impact of urbanization as a one UN phenomenon. And this is led by the Secretary General. There is a quadrennial reporting to the Secretary General on the progress on the New Urban Agenda. And this really was recently just looked at in this past 6 months at the UN and at the General Assembly. It was 2022 was one of the quadrennial reports, and progress is being made, and there's a lot of innovation. These are obviously all voluntary reporting requirements, so there are people that are left out, but every country is supposed to be looking at this issue of urbanization as part of, and developing plans as part of their attention to the SDGs. Next 2 slides, I just wanted to touch on learnings from COVID, because I think this is where international and national attention to cities really began to come into its own. The reveal of the terrible inequities, which anyone involved in urban health or public health work had known about for many years, but the issues of frontline workers, the issues of challenge of housing, et cetera, the importance of involving communities in planning. And I think in unpacking the major learnings in COVID in New York City, especially, and I know in New York State, the failure to really emphasize the development of primary care and the engagement of primary care and local health departments with that of hospitals was a major problem. And the emphasis on hospitals turned out to have been obviously needed because of the intensity of the epidemic at the beginning, but a major problem later in terms of information, in terms of vaccine, in terms of testing, et cetera. The second slide really raises the last lesson. So this is from a really nice piece put out late in 2021 by UN Habitat, looking at cities in pandemics. And it's a very, really nice, important mechanism. And again, you can see they emphasize the governance mechanisms, political support for work, and similarly, the importance of a balanced strategy looking at multiple sectors, but again, looking at urban and rural areas. And when you look at cities globally, very often our colleagues, we've just completed a survey of National Academies of Science worldwide, coming out of the Inter-Academy Partnership, looking at what academies of science and medicine are doing in the urban health area. And this issue of rural-urban connections, not only for food supply, but also for the economic development of rural areas in parallel, has very strongly come out of Africa and some parts of South Asia. Obviously, it's not been that developed in the global north, but it's an area that if, and many of our colleagues in Africa, they say that if 20 to 30% of a country's GDP comes from its agricultural sector, they need to think about a balanced investment in rural and urban areas going forward. So I just wanted to look at a couple of the key urban health challenges and what cities are doing to address these. Heat, you'll recognize. I was in London the week of the hottest week of the planet, I don't know, the universe, I guess, and traveling to Manchester the day after, the Tuesday, when all of the wiring for the trains was put at risk. This is obviously a longer standing issue and one that's getting a lot of attention now in cities. And then air and water quality are two others. And just to touch on those briefly, these are different phenomenon that occur in cities. Next slide. This is something called the heat island effect, which you may be familiar with. It's about the concentration of surface temperatures in cities. This becomes a huge issue in the global south. You can imagine when temperatures get to be 110, 120, 140, the inability of the workforce to perform when there isn't the infrastructure to cool. And this is just an example of the kind of work that's going on the issue of the heat island effect and this concentration downtown, which doesn't change all that much. The heights are still the heights, regardless of whether it's day or night. But you can see the effects of reducing heat when there are plantings, when there is great green space, when there are, these are not too many examples of water, but also if you have bodies of water near and around cities. Actually, the city of Milan is reclaiming a lot of wetlands around the city to try to promote this sort of positive effect on heat in cities. The next slide talks about energy. The LEED certification is something that's pretty global at this point. I just wanted to put this in there because it was really led by the private sector in the United States. The U.S. Green Building Council set these standards, and cities buildings are in some way self-reviewing. There's a internal monitoring from this council, and at least in the U.S. and in New York, this has become LEED certified, really has become a selling point for social marketing. Many of the brand new buildings lead with the fact that they are energy compliant and having hopefully zero energy effect on the environment. Next slide. I mentioned earlier that the C40 cities have really been focusing on global pollution levels. This is just a slide to show where these are. Obviously, there's a great overlap between urbanization and pollution levels, represented in the dark colors, and you can see the major problems of pollution. And obviously, those low-income countries, in middle-income countries, especially Africa, but in other parts of the world, that really suffer from the failure to manage development in the global north. Next slide. And I mentioned C40. This is a set of standards that this is the Paris Agreement rather than the Paros Agreement. Sorry for this typo. But the Climate Action Plan, and cities and mayors in cities make pledges to address these 8 sectors, which are all sectors. I think the food sector is even mentioned in SDG 11, and to meet certain goals. And they self-report on an annual basis. And this C40 represents about 96 member states and 25% of the global economy. About 700 million plus people are involved in this network. And I believe the most recent chair of C40 is your mayor of London, Sadiq Khan, has been the chair over the last year. I don't know when that turnover takes place, but there's a lot of innovation going on in cities to address the goals of this pledge. Another area in cities that's getting a lot of attention, next slide, is the so-called smart city. This is a diagram of a digital connection from a New York City plan, New York City 2050, which was a precedent started by Michael Bloomberg, but happily continued by subsequent mayors to have an integrated strategic plan for New York City that covers multiple sectors. And this just shows you what they see as the long-term goal for a connected city, starting with buildings and then moving into the transportation area. So many of the sort of so-called smart cities, they have, especially in India, become a bit of a political football, depending on whether Microsoft or Apple gets hold of the country leadership. So they're selling technology. Sometimes that gets politicized, and then but cities are being recognized in many parts of the world as smart cities, and then trying to really deal with how digitization and connectivity can improve, and in many instances improve health, not always, but in many instances. Next slide. Another area that I stumbled on, this is what happens when you teach, you start reading things you'd never read, but something called biophilic interior design and external and architecture, which I found really, really interesting. There's a work by these two folks that are actually Italian researchers going back to 2017, really looking at improving greenness in the environment and nature and space. It's both, you can see on the top cluster are, we see this a lot in buildings now, making sure there are windows, that you have access to airflow, that there's water, often in lobbies of buildings, that the light is changeable, and that there is connection to sort of natural systems and natural shapes. The natural analog looks at the shape question. Is there a use of wood? Is there a use of comfortable shapes like shells, like circles in buildings? And then the nature of the space. How do people feel about it when they go there? Are they looking forward to it? Do they feel safe? And this is beginning to have an increasing, interesting impression on the quality of life, both in the workplace and in people's homes. And I think a lot of the attention to workplace quality of life has been really strong during COVID, and sort of reflects the fact there are a lot of people working here. And somebody asked, I saw breezing by in the chat, what are the world's most sustainable cities? And not surprisingly, Copenhagen is number one, Amsterdam number two, and then Vancouver. And interestingly, Curitiba, Brazil. Brazil has been a real leader in Latin America, especially in the transportation sector. The next slide is a picture of biophilic architecture in Singapore. This is a high-rise residential building in Singapore, which shows how plantings on balconies and others has been built into the architecture. Next slide. These are sort of strips of green, sort of walls in Mexico City along the highway there to try to improve the quality of air and the sort of aesthetics of that city. And then if we move to Ciclovia in Bogota, this idea of complete streets is a pretty well accepted notion now, where streets are blocked off for a period of time for kids to play or for bicycling or for pedestrians. This actually started in Brazil in 1974. There was a big protest because of a failure of access to public streets. It has really continued, and this model is now very common worldwide. And the other really important part of the Ciclovia model, and I think you see it in complete streets worldwide, is the engagement of communities in identifying the areas in which communities feel comfortable congregating or wish to congregate, or sometimes historically used to be places where people congregated that have been sort of obliterated by buildings, and building on that information to engage communities in activities and other things that they really will bring people out, give them exercise, give them a stronger sense of community. Another innovation in Colombia, if we go to the next slide, is this is the Transamicable. This was, again, on the left-hand side of the slide, the use of gondolas, where the technology goes back a long time, really, to their early 1900s, to bring people down from the hilly sections, largely the slums and informal settlements in Bogota, down to the bus stop there, and then looking at having co-opt the jitneys and the other sort of gas-driven vehicles, so that they began to own the people who've been driving those taxis and gas guzzlers, if you will, to set up bus stops to co-opt them, and they own the buses there, and then the buses meet the gondolas and bring people into the city on transit buses, and they're cycling lanes and walking lanes and sort of limited car lanes. And this went into full effect in 2015, 2019. It's been very nicely, there have been now sort of 2,000 bus routes connected to this intervention, and the distances are very carefully measured to allow for walking and cycling. So a lot of people have done some really great research, a lot of Colombian researchers, and it's been published in English, looking at the effects on air quality, on exercise, on people keeping their jobs, on ability of keeping people getting into work without long commutes. Last couple of slides. This one is really what we in urban health like to say. Urban health is the window into all the SDGs, if you think about it. Some nice work by a number of folks trying to look at the connections between the SDGs to help policymakers know that if you act in one area, you may be having a disproportionate negative impact on another. But you can see here in this analysis, these are colleagues in Barcelona, actually, at the Institute the Institute for Urban Studies there, that have looked at these connections in urban health and have a nice paper that's cited there about this, describing this and the importance of governance. And so what the next steps are for people working in urban health, next slide, is that as part of the SDGs, and I know there's a lot of debate now whether they should be abandoned, whether they should be continued because of the impact of COVID. But the idea is that each country is really asked to develop an urban policy that looks at health in the broad way that we talked about it. China, India, some of the very large countries have done this along with a number of the smaller countries. The essence of these plans is they promote the kind of interagency and intersectoral governance that we talked about. Obviously, decentralization strategies are not always possible, depending on the degree to which local government has authority to affect the things we've been talking about. Strong and effective governance at state, territorial, and local level is important. And then helping people really look at where the big money goes into infrastructure, it goes into transportation, housing, and how can you influence loans, World Bank loans, local development bank loans, government decision-making in infrastructure to be pro-health rather than negative to health. And then the strength that's been revealed over a very long time for a place-based strategy. When you develop a focus on place-based communities, you can bring data together from multiple agencies and cities. We're doing a project here in New York now, which we can talk about if there's an interest. But I'll leave you with the last note of why cities are important to achieving global health. The World Economic Forum, I'm going to read this, notes that the median population of country members of WHO is 5.5 million, and 54 cities in the world have higher numbers of inhabitants than those those major countries. So this is a conference coming up in Valencia, Spain, our international conference on urban health that's been going since 2002, and we welcome you to, if you can't make it, if it's too late to plan, please come next time. Thanks very much, Christine. Over to you.
Jo, that was great. Thank you. And I should have said right at the beginning, but you could probably tell, we have recorded, so the recording will be available for everybody, and you can access Jo's great slides. I thought that gave us so much that was really interesting. I thought the issues around things like vertical organization was particularly interesting. A number of people have made comments and interested in making some questions, so I'll ask people one by one to come off their mic, put on their video, and ask you the question direct. But just to add a bit of some of the work that C3 has been doing, and which we're really proud of, is real local working with people, particularly in some of the disadvantaged areas like Queens, to really try and empower people with some understanding of their environment, and hopefully make them really angry about the disadvantage in low-income areas. But our newest trustee, Mark Wakefield, and he has other roles in life other than being a C3 trustee. But Mark, you raised a couple of issues. Perhaps you could ask them, and then I'll ask Denise Stevens to ask her question.
Thanks, Christine. Hi, everybody. And Jo, great presentation. Thank you. My first question, which I sort of hastily typed in, but is probably not terribly well articulated, it strikes me that actually when you listed the factors that contribute towards health issues, and you had 5 or 6, I think, really it strikes me that inequity in all its forms is the fundamental issue, and whether that's reflected through diversity or and. So if you've got money, you can afford to do things, you can choose where you live, you can choose how you live, and et cetera, et cetera. So I just wonder whether we're in danger of sort of masking or conflating what is the fundamental issue here, which is inequity. And then my second question, which you touched on, I think, very briefly, which is, so there are clearly some cities and areas and places doing things not very well at all, judging by some of the maps that you showed. But if you could choose which city that you wanted to live in, notwithstanding all other factors, but based on cities you think are doing it well, where would you choose to go? Who's doing it well?
Nice question.
Yeah, I'm afraid I may have lived in New York too long to answer that question in a different way. But anyway, I'll try. I think one point I tried to make, and I think you raised a good point. Inequity is one of the 4 major dimensions in thinking about urban health and urban health research and urban health practice, and certainly it cuts across. And I think all of the areas that we talk about. I think the point I was trying to make, and I'm a pediatrician by training. I started out with most of my work in clinical medicine and management and policy in the clinical space, and kind of lost, I have to say, I kind of lost interest in the ability of the clinical space to make the kind of changes I was interested in about 10 years ago. So I'm sort of I'm a clinical type arriver into the urban health space. And I have to say, I've been really deeply impressed with the fact that I have yet to meet anyone working in urban health who doesn't have that concern about the inequity that you raise in their DNA. I mean, it's really interesting. You just can't escape it. And the reason the researchers are embedded in it is because they realize if you round up looking at research data to city level data, you miss the granularity in a city. So it's kind of built into a research design. You don't even have any credibility as a researcher unless you're thinking about it, which is really important in terms of the evidence base that gets developed. They can't leave it out, if you know what I mean. So I think that's hopefully an answer to your question partially. I mean, I mentioned Stockholm, Amsterdam, the others. I haven't been to enough cities to really answer your question. Honestly, I'm kind of, I lived in London for about 3.5 years, and I sort of consider London a kind of polite New York in a way. But I think I'd have to err on the side of I'm a little bit too embedded in the social and cultural realities of New York City, and I do see things changing. I think part of my answer to that question, and we probably might all share it, is what are the cities we know best, and do we really feel like they're doing a good job, or that we can contribute to their making change in the right direction. So at this moment, I'm feeling in a world where I'm not feeling too positive about a lot. I guess I'd have to say I'm okay still in New York.
Great answer. Denise, can you ask your question of Jo, and
Sure,
then I'll ask Carol.
Yeah, sure. I think it's very similar to Mark's, but I just want to frame it a little bit differently. And that is, can you think of any examples? I mean, you asked about your preference, but any examples of good governance where you've seen that cross-sectoral collaboration that's necessary to achieve a lot of the SDG goals, including number 11?
It's an important question, Denise. I think when the article that's cited on, from our colleagues in Barcelona on the SDG connection, Barcelona has always been a bit of a leader, but I think it's a really nice article looking at a broader health in all policies approach. I've looked at a lot of the literature. There's a source book that UN Habitat and WHO put together, and I can't, retrieve the numbers. Next time I do this, I'll have more cities to give you because you're helping me with the questions. But I think a lot of the literature that I see, other than that particular article, is a mayor and or a city that has focused on one of the sectors. So there's a lot of nice writing up about focusing on the transportation sector or focusing on the housing sector or building materials or green space. I think a number of Berlin, others are really putting a lot of investment in green space and reclaiming it and building it up. But I haven't seen much on the sort of health in all systematically, kind of looking at all the outside, the things around the outside of that bubble. Because it would imply, and even Bloomberg, who was called the public health mayor, frankly, he had a very aggressive, positive transportation secretary, and he worked with a sort of health in all perspective on things like, food, smoking, and others, using regulatory and zoning frameworks that were executive authority, but did not necessarily reform, certainly outside of Manhattan. The equity issue was really missing, Mark, in response to your question and the work he did, because the outer boroughs of New York were not included. Our subsequent mayor then injected the equity formulas into that, and a lot of work's been done to make green space, bike lanes, all those things, available outside of Manhattan. But I don't know, Denise, you're a academic in this area. Maybe you have some answers. I think places in Australia might say they're working more effectively on this. What would be your nominees?
Yeah, I don't think anybody's doing it particularly well yet. I think we're sort of tackling little pieces and little chunks of it at a time.
Yeah.
But I think it would be brilliant if we had, and again, this is always a challenge with translating research to practice, right? We have these great ideas and we know we need multi-sectoral collaboration, but how do you do it and how do you do it well?
Yeah, I think
and
you're right.
And you have to be you have to want to do it. Somebody has to do it and say they're committed to doing it. And there's no city that I'm aware of that's done anything like this.
Well, and you have to, I mean, it's back to political leadership. The euphemism is governance, but I think, one of the things I find in, teaching global health at a school of public health is I sort of make the students realize that, especially in public health, you're going into government for a large number of you, or you're going to have to deal with government if you're really going to make change. And I think the politics of public health has been, reasonably reflected over the years, but perhaps it's gotten a little bit lost in the shuffle. Getting the political leadership, you either win or you lose, because they can undo everything that's been done by their predecessor if they want to.
Absolutely. Yep.
So despite my encouraging, Denise has stayed hidden. And given that it might be very early, I should perhaps caution my request for people to reveal themselves. But the next question comes from Carol Baldwin, and it's 5 a.m. where she is, and she looks perfectly respectably dressed. And then I'm going to ask Alistair and then Molly. But Carol, over to you. You may still be, I think you're muted, Carol. Isn't it amazing? After all these years, we still do it. I did it just before we joined. Carol looks as...
There we go. Okay. Yeah. It's a little after 5 a.m. here, so I'm barely ambulatory at this hour. But I do, Mark, I really appreciate your comment on health inequality. I do think that's a huge issue, and I think that word should be emphasized even more. Jo, I have kind of a scenario question to ask, and we talk about cities and that kind of thing. And I live in a townhome complex, and so it's transgenerational, and we do have it's multi-ethnic, and so these are like, to me, these are like mini communities, whether it's apartment complexes or townhome complexes or that kind of thing. And I lived in East Asia for a year, and in particular on Okinawa, we had these little towns, little chos, and they each one had what was called a kominkan, like a community center, and they were fantastic because the older adults during the day, the men would go across, they'd go to it and they'd play Go, and the old women would be there, and after school the children would come, and there were games and things like that. And every month, their health system sent out, in particular, nurses, and they did blood pressure checks and finger sticks and height and weight, and they would do immunizations when relevant. And so we were addressing health. They were addressing health across the lifespan, and they also had the blood mobile come out once a month in each of these communities. And oddly enough, yesterday I was talking to one of our board members about setting up a combing con type thing at our townhome complex and seeing about using like our College of Nursing here in Tucson to come in and their nurse practitioner students coming in. I'm not sure about our public health program, but doing the same kind of thing, but also trying to get people to start communicating with each other. We aren't really out of the pandemic, but people are starting to come out of their homes en masse now. And especially in America, we've got a lot of, I mean, it's not a secret, there's a lot of divisiveness going on. But if we can focus on developing community in this small way, particularly with health, everybody's into health. We do have older adults. There are disparities in terms of access to care across the lifespan. And I'm wondering if this is something that you all have talked about or thought about, if there's any practice that's been done, not just the research, but practice, drawing from these small communities and setting up community based on health issues. Everybody has health issues. We don't have to talk politics. We can talk about basic health and then growing from there.
Thanks, Carol. Thank you. Over to Jo to comment, and then
Well, you
I'll
raised,
ask Alistair.
yeah, you raised two really, I want to, before I get into the older person thing, I think you pointed out one of the advantages of density in a city where you have people living and you can have services provided to more people through that access question. So I just wanted to jump on the positive side of the density question there. The Age-Friendly Cities Network that started out of WHO about, it's probably been 10, 15 years now, 20 years maybe. Everything seems like it's 10, but it's really 20, the time issues. But it's a very important answer, I think, to your question in some ways, Carol. It really, what WHO did starting in the Age-Friendly Cities Network, and Euro was probably the most aggressive there, but it's been extended, is really changing the paradigm for aging to think about a life length perspective and healthy aging rather than, the sort of disaster predictions. And I think many of the examples like Japan and others where the percentage of people over 65 has been growing and increasing dramatically are really places to look for innovation. But I've seen in a number of the age-friendly documents coming out of WHO. I mean, there's age-friendly primary care, there's age-friendly housing, there's age-friendly sort of everything that people have really looked at, and many examples of practice. And one of the areas I think that's important in the United States, and I've seen it here in New York, you mentioned trying to get, having a nurse practitioner come out to, sort of communal living arrangement that you have, which is definitely increasing, and older people are part of that move, is in the US, you get what you pay for. And I think what happens a lot around the health space is if you're not paying for that health expertise to be in that unit, it's harder to arrange it. I mean, you may get the nursing students and others. And the interesting part here in New York that's been interesting to watch, because we've been trying to do health in all policies in New York State, with some success in an executive order of our previous governor, not yet undone by our current governor, for a master plan for aging. And the reason why local officials are interested in age-friendly cities, we did this in New York about 10 years ago, is because older people vote and they buy local. And they have enormous power in their cities to advocate for change. And those of us that have worked in public health and tried to get money for public health, it's like a losing proposition most of the time. But if you can align with the needs and requests of older people in improving health, you have a really, really high leverage. What we did with city council members in New York was mapping where older people lived, and most of them saw that sometimes up to 30% of their population were older people. They're very interested in local small business. And most older people buy locally in terms of their getting out and we've just seen that. So we're on the piggyback of age-friendly, whatever. Anybody says age-friendly, I said, calm down, because if you can fix it for older people, you fix it for everybody. And that we've seen. I mean, all of that is really important. So I'm glad you brought both of those issues up.
So
Yeah,
we've got only 5 minutes left. So questions have got to be really quick if we can get them all in. So Alistair, followed by Sarah, followed by Molly. Right, Alistair, over to you.
Thank you, Christine. I've got really 2 questions, and they're both about inequalities in a sense. And I haven't written the second one down, but I'll tell you about it quickly. The first one is that I've said that cities hold 50% of the population, but produce 70% of the income. And I've said that's problematic. Is a banker really worth 100 farmers? Is a professional footballer really worth 10,000 farmers? Bankers and footballers are essentially products of a monopoly situation. And the farmers are essentially pure competitors. And so how does that skew the way that rural areas are discounted when it comes to levelling up? Now, the second one is basically, again, about where the money is. And it's to say that public health basically gets very little money because there's no money in it. All the money goes into, and the agenda is set by the pharmaceutical and other profit-making areas of healthcare, which are therefore managed to skew the agenda so that they get paid most.
Okay, Jo, over to you.
Oh, by the way, what I wanted to say was, look, I don't want to feel as though I've been too critical, because I think it was a great tour de force for what it was.
Well, I'm not gonna ask your first answer. I don't have an answer for your first existential question. It depends on what society values, unfortunately. The second question, though, I think is a really important one, and I want to make the emphasis. I'm talking about health, not healthcare. And I think that's kind of, it's not, it's not only healthcare. I don't want to exclude healthcare, because as you point out, it's very powerful. There's money there. The workforce is concentrated there. It gets the political attention of the elected officials for sure at many levels. But if we begin to talk about health and understand these other determinants of health, then you can really talk about some of these pro-health decisions that are going for huge amounts of money in transportation and housing and these infrastructure projects. And I've kind of lost, I really don't think, I mean, I'm sitting in the United States watching this all the time. I think it's very unlikely that we're ever going to get a dime out of the personal healthcare delivery system for public health. So I'm trying to help our public health folks really begin to come up with conversations with these other sectors, which have hundreds of millions of dollars invested in this infrastructure, which can be really important. So I'm like, that's one of the reasons that you raise, I'm off healthcare as a solution. I mean, it's got to be part of it, because they're huge institutions and they have huge importance in the communities in which they sit. And their capacity is there to be an enormously positive partner in this. But I think a lot of the big money change is going to happen in other sectors.
Thanks. Sarah Deakin, and if there's time, we'll just squeeze Molly in. If not, I've just warned her she might be a victim of FHB, for people who know about family hold back and let others in. Sarah, over to you. She's still there? Sarah Deakin, to ask your question? Yeah.
Oh,
great.
hello. I think mine's been answered actually in that very last question,
Great.
which was about health in its broadest sense. About I've even had conversations about doing health research within this area, and people only really being interested if it involves the healthcare system in itself. So they're not interested in, say, public health or population health research. They're only interested if it reduces patient times in hospitals, or if the outcomes are very patient focused. So it can be extremely challenging in this field to get the message out there to even health professionals that say work in hospitals or in that sort of arena, to look at it in the widest sense.
Yeah. There's some, I mean, I think a lot of people are recognizing that you've got to give a return on investment analysis if you're really trying to make a case for investment in some of these public health areas. So there's some pretty good data in that regard around cities, the Urban Institute in the US and others. But I think the other, that making that economic argument, you're right, you have to really do it. I think the other, I was going to say, in terms of getting the healthcare delivery system involved, welcome to my world for the last 10 years. I mean, it's really, I mean, you want to, and meeting with people in other sectors, but people are probably surprisingly responsive. The line I always use with clinician audience is, you know, you're doing great work in the examining room, but then you're sending the patient out to the same conditions, which probably had an enormous influence on triggering and sustaining their health problem in the first place. And they kind of get that. And then they say, but that's not my responsibility. You know, I don't know how to do that. And then we say, well, what about the partners with the organizations and the others that are taking an initiative there? And that's where the sort of hospital leadership, the sort of enlightened, I think, hospital systems, there's a notion called the anchor institutions in the US where hospitals are really being asked to be much more aggressive in that regard. So it is an important dialogue to have, and it's new to a lot of people. Mercifully, it's not new to as many people as it was 10 years ago, but it's important.
Jo, thank you. And thanks for not only a great presentation, but great response to some really interesting questions. Our next international seminar is going to be in London Global Cancer Week on the 17th of November at 8:30 UK time. So we're back to breakfast, and Fiona Bull from World Health Organization will be leading a seminar on the impact of physical activity on preventing cancer. So once again, Jo, a really big thank you. Great presentation, really fascinating topic, and stimulated some great questions. So thank you to everybody who came. And Jo, thank you for the great way you answered and handled and discussed them. Thank you all very much indeed. Thanks for joining.
Great audience with you always, Christine. Thanks very much.
Thank you. Bye.